So today our goals and objectives are to review the history of HealthWorks, how this collaboration originally started, its evolution, discuss specifically what HealthWorks ACT or HealthWorks Act is, and where we are today. So Kurt will lead us off with our origin story.
Great. Everyone loves a good origin story, right? I mean, I think for us it's important because I think we're trying to really, as we talk about this with others, try to have an eye on sustainability and replicability. We'll talk about those things later too. Of course, in Vermont, each health service area has its own unique features and partners that work together in different ways. And I think the last thing we would want to do is paint a portrait of this as something that sort of needs these 3-4 particular entities to come together in this way to do it. Although I think there are some sort of more universal lessons about it. We're trying to say something more useful than the way to do this, if you're interested, is to muddle around for a decade together. Although what we did was muddle around for a decade together. It started about in 2013-14, actually the Groundworks, which was then Morningside Shelter. It's sort of a whole different time in the world where the drop-in center services and the sort of shelter services were not all coordinated by one entity in our region, which sort of has had its own history to it, which I won't get into. But they approached me and some others at Retreat Leadership, our CEO at the time, Rob Simpson, some of you may remember, after going to a conference in Pennsylvania where they had embedded some clinicians doing sort of trauma work in sort of more long-term shelter populations, sort of observing that so many folks had complex and difficult issues with trauma, and wondered if we might replicate that somehow. And honestly, I wasn't quite sure how that was going to work. I did, sort of felt like, oh my God, trauma work is hard enough to do when someone is willing to do it and comes to your office and you know what codes to bill, and you're taking all those things away from me. I just have to go do it out in an environment we don't have control over, with a population that maybe we haven't assessed in the same way, and with no clear path to reimbursement. So, of course, we said yes, despite the obvious obstacles to it. I mean, it seemed like the right thing to do, I think, is really, if you get to why did we do it, is because there was a genuine community need and partners came knocking at our door and said, help us. I think we wanted at least to try. So we did some digging and we tried to sort of find some funding, and we tried to find a willing clinician, and we got just a little bit of funding for only like a little part of an FTE. So we're able to start someone at one shelter site, the sort of more longer term shelter site, Morningside House, with about 10 hours a week of time. But then it's sort of like we got them there, and then immediately the question of what were they supposed to do, and how do we know if it worked or not? That sort of wonderful measurement questions were immediately in front of us. So well, okay, great, we've got people in need and a clinician, and they're supposed to match and sort of make it work. But actually, we got a little nervous about actually when is someone a client of the retreat? When are they in therapy? How do we define these things? Do they know that they're in therapy? I mean, if they talk to us, how does that mean that they're? So we had to sit with the lawyers for a while. And we sort of drew some distinctions. As I said, draw a bright red line down the middle of something without a bright red line down it. And we said formal and informal services. So there was a sort of component where we could sort of have a consent process with someone, which I'll talk about in a minute. Where they sort of agree to work with us in a certain way related to their mental health needs. And then there was sort of a relationship where we tell people explicitly we're not doing things in that way, we're not documenting, but essentially the social worker is just working to engage with folks sort of in the milieu. And that seemed to work reasonably well, although it took a little bit of getting used to. And that was a model we practiced for a long time. Now, it's kind of interesting because actually immediately it became clear that there were a lot of people that didn't necessarily want the thing that we thought they wanted, which was to sort of sit down and do a lot of trauma work. And actually, we're going into basically their homes, and maybe they didn't really want us there in the first place. Maybe there's a deep distrust of institutional services. Even the word social worker doesn't necessarily create warm and fuzzy feelings with everybody for understandable historical reasons. And so there was a a lot of hesitancy about how to engage, and a lot more comfort engaging in informal ways than formal ways, which made the reimbursement picture, made us glad we had some grant funding, I guess, because it wouldn't have worked so easily the other way. And we wanted it to seem sort of natural. We wanted to have some respect for the idea that we are in people's space and in people's business. And so we tried to sort of keep the living spaces and common areas private for people, but we had some separate spaces close by where we could be in closed-door spaces if needed, or open-door private spaces if needed to. And that continued for a while, actually. A number of years we went through some different clinicians. We sort of found also that you can't just put any social worker into these environments. You can have wonderful, amazing clinicians that actually don't do well with this kind of work. It's a little bit more chaotic. It requires a little bit more, a little bit more. You got to kind of go and reach people in a way. You can't sort of expect that they're going to come and knock on our doors. Reticence is not really a great quality in that. So we sort of went through different kinds of trying to define this, trying to create a match and the rest of it. And then some interesting things happened, which is the merger of the homeless serving organizations in town, which sort of brought some of the shelter systems and the drop-in center under one organizational banner. And then in 2016, Brattleboro Memorial Hospital, and really a pivotal moment, I've got to say, joined the collaboration with an embedded nurse. They also got some funding for that, I think, in the early days, to focus on care coordination and connect people to primary care. And then we started to meet as a group. That was sort of the big thing. We met as a group regularly. All right, we're operating under our own separate organizations and banners, and maybe we don't even have a necessarily coherent, unifying idea about exactly what we're all doing together, but we would get together periodically in the basement of the medical hospital usually. And Becky started to invite other people, so here's the ER nurses. Oh, okay, great. Here's the ER nurses. What do they have to say, And we found they were having experiences sort of like we were, that they were sort of interacting with this population, feeling very helpless, actually, feeling like we've got to do something different than we're doing now, but we don't know what the different thing is. And so it was a sort of time of frustration, but there was an excitement of joining. At least we could talk about it together, And we said, well, let's just see, let's talk about cases. And we did some initial MOUs and things like that, so we could talk about patients without breaking rules and things like that. That relationship deepened, and BMH sponsored a respite bed at Morningside House. If you have more questions about that, we could take it in Q&A. That continued up until the COVID pandemic, which sort of shifted things. And beyond that, too? Or did it end with COVID? And beyond that. Yeah. And beyond that. It continued until April of this year. And then HCRS also joined the collaboration with the SUD, especially. They started coming to our meetings, too, and we started to talk about all of this together. We sort of said this is sort of key services were informal, flexible, and responsive to client needs, but largely separate except for this, and we weren't really gathering data. But we started to talk about data a lot, actually. We started to say, we should be gathering some data. We should be looking at this. We should be thinking about it. But our sort of philosophical arc of this was that the system as it exists for everybody actually should work for this group too. Like if you were to really push us, it's not working, but it should work for them. And what we need is to sort of bolster it a little bit, to sort of give the system a little bit extra, give the people a little bit extra to help them get to primary care and sometimes wound care because they've got complicated wounds from sleeping rough, or get them to a psychiatry appointment, or get them to a sleep doctor because they haven't slept at all, or something like that, or get them hospitalized or into a nursing home or something like that, through the usual channels and pathways. And I think. But as time went on, we sort of had the impression of increased complexity. And we actually have some data on this I'll show you in a minute, because it wasn't just a perception. There actually was increased complexity during this period. Things are actually getting harder even as we're struggling to make it better. And I think we started to lose some faith in the idea that all the system needed was a set of Band-Aids, basically. You got to splint the wound and move on or something like that. And it was sort of, the conditions people were living in were really harsh. Like there's stories that are not so easy to sort of tell in a sort of professional company. People really living with complicated open infected wounds or at risk of, death or dying at any moment in time. And remember, this is even before the fentanyl part of our pandemic with opioids really, really ramped up to the worst part that it was going to. But still, people are dying what felt like needless sorts of deaths. This might be a little hard to see, but this is sort of we actually did some statistical analysis on survey data that we had that the Groundworks had for sort of all new contacts with folks coming into the seasonal overflow shelter and the permanent shelter over a series of years that sort of ask in the same way self-report questions about struggling with mental health problems, substance use, physical disability, chronic health conditions, and domestic violence. And there was, as you can see, the general trend is that 2016 to 2018, these things actually step up gradually. And actually, these have p-values. Most, but except for a couple, have p-values of 0.05 or 0.001. So it's a sort of very strong, not just sort of correlational, but it looks like something is really happening here, making the sort of world worse. And I think a lot of it had to do with the increasing crunch on housing and pressure on services and the sort of, I think, traumatized state of the world that has been hard for all of us, but I think it's sort of hardest for those who are most vulnerable. And so that led us to begin to talk about different ways of approaching this.
So a real pivotal point in this project and this collaboration that we had collectively was COVID. If we think of something positive that came out of COVID, is that everybody, for the first time in our community, was in shelter. We had people who were there. We had a collective reason to come together and address needs. It was to keep people out of the emergency room, a population who would be together in spaces that were confined. Historically, that was a concern, that it would overwhelm our emergency rooms if this population got sick with COVID. So BMH decided to take a proactive approach, and we already had a nurse in place. We had a social worker in place, and we decided to, when we redeployed staff, to send a nurse practitioner to the Quality Inn, which is where the majority of folks were sheltered in our community, along with a psychiatric prescriber, because what we were hearing was that the psychiatric need was so much that we needed a way to address it. Now with people sheltered in a space that was harder for them to get away from other people that were posing problems for them, or seclusion in general. Some people were good with it, some people were not, with independent rooms. We also had folks that were experiencing overdose because they were alone in spaces. So there was a lot of complications during this time. But what it did is that it organically formed a team. It formed a team of prescribers, it formed a team of nursing, it formed a team of social work and case management. This was a time where there were case managers down at Groundworks that were redeployed to this area as well. So organically a team was forming, and we actually saw a difference. People were coming together, people were engaging in care, people were getting vaccinated, people were getting tested. It was actually amazing to think about the benefits of the motel program in our area. At that point, we decided, okay, we can't change the system. We can continue to try and move the system. We can do that, but what we can do is we can provide on-site care for folks who have these significant challenges. How can we do that? How can we make this sustainable? How can we imagine coming together to form a formal program to help people with our informal relationships, really, with each other, as a team, as organizations? So we decided we actually leveraged some funds that we received from, it was a DSU project, if I recall, around rapid access to medication in our emergency department. So we leveraged some funds that we received. The retreat and BMH worked together on that project. We received some grant funds. And we leveraged those funds and decided collectively to hire a consultant Her name is Maggie Foley, and she is by far amazing, so a small plug for Maggie Foley. But we hired her to help us figure out what kind of program we wanted to develop. We knew we had to do something, but we weren't quite sure what it was. We had somebody in our development team who had worked previously on an ACT team, so ACT, Assertive Community Treatment. We came together, we had a lot of conversations. I will say this was over a year and a half of developing the program specifically, of Friday afternoon, 3 p.m. meetings, because that was the only time we could all find time in our schedules to come together and do this. So if that says anything, it says that the drive was there, because 3 p.m. on a Friday is not where we are all at our best, for sure. So,
during the pandemic.
During the pandemic also. I mean, not that any of us were redeployed or doing 5 other things during this time, but there was a drive, and there was a drive not only by what we will get into later of the steering committee. There was a drive of executive leadership of each of our organizations. We collectively had previously come together in what's called the Regional Psychiatric Strategy Committee meeting, where HCRS, the Retreat, BMH would come together to talk about ways in which we were serving folks with mental health needs in our community. And so that felt like a natural place to bring it to that table, to get buy-in, to make sure that this wasn't Kurt, Becky going rogue and trying to develop a program, but it was the intention of our organizations, and really their I don't want to say approval, but really they said, this is important, we agree, take a year, go explore this together. So we did. We then decided on a assertive community treatment program. So for folks who aren't aware, assertive community treatment, it is an evidence-based model. There's a couple different tools that you can use, a TMACT scale or a DACT scale, both of which are evidence-based and used widely across the country. It's really designed to support folks with significant psychiatric needs, and another caveat to that is that they are unable to really access care in the way that most people can access care. They have an inability to get to appointments. They have significant needs in terms of being unable to be in spaces with other folks at times, or really arrange their life in a meaningful way. So we decided on the TMACT scale. Great, done, check. The other part that we had to wrestle with really was the criticisms of ACT. And we have done that in multiple ways, and Curry will speak to that next. But we had to decide, how do we take out some of those parts of ACT that feel a little bit more paternalistic, that feel a little more coercive, and make it a program that holds our values, not only as organizations, but as a state, I feel. So the other part that we really had to focus on was that people with a substance use disorder couldn't be an exclusionary factor. So we really needed to look at harm reduction as a way in which we were going to provide these services. And that felt really important and was really the basis of the program that we did develop. And historically, these programs are reimbursed through insurance, through state Medicaid programs. So we developed a program. We got approval from executive leadership in our organizations. We brought it back. Yes, yay. Now came, how do you fund this thing? Right, we had an initial budget of, I think, $1.3 million. How do you find $1.3 million to do something that really isn't done in a way collectively in this state? So we hustled, and we hustled hard. We went after HRSA grants. We went after earmark funding. We went after private donation, philanthropy in the state. We did everything, and And we received a lot of money to do this. And we are so thankful for that, not only from the federal government, for the support for the state as well, because it has allowed us to do this today. And another plug for Maggie Foley, side note, she did score a perfect 100 on the HRSA application that we submitted, which is a feat in and of itself. So we are very proud of her, and she was very much a part of doing this work with us. So now we have funding, we have a program, we have funding. How do we manage this thing, right? How does 4 organizations come together? And so we explored different ways. We went to our legal counsel and said, hey, don't think this is a total wild idea, but we want to do this thing. We have this money. How can we make it work? How can we do this contractually? How can we protect our organizations? This is new. This is a population that is really risky from a liability standpoint, I think. And how do we do this? So we got the recommendation from our legal counsel that creating an LLC was the best way to go. And Jess will speak to the overall structure of the LLC and the organization in a little bit. But we did that. We got insurance. Took a while, but we got that. And we launched the program officially in February of 2023, which was amazing that we even got there. So a dream years ago, a program and relationships in the making for several years, and we finally have come together to create something to serve a population of people that our organizations, quite frankly, are not great at serving alone. We can't, in the emergency department or in the hospital or in primary care, serve this population of people in a meaningful way without our partners. And we realized that. And so we did something about it. I'm going to turn it over to Curry now for implementation.
So how do we do it, and how do we do it differently a little bit? Because like as Becky was speaking to, we chose ACT, but we are very aware that ACT traditionally had some things we didn't like, right? Vermont is known to do things differently. We want to do things differently. We want to do things better. We really pride ourselves on that. So I'm going to talk about a few ways that we do ACT differently. The first is we wanted to add primary care as a big thing. We want people to have access to primary care as they are and as they are showing up. So one of the barriers to people getting really good comprehensive care is not being able to keep appointments, being discharged, being under the influence, or being in states of being that makes it not conducive for them to show up for appointments, right? That could be in states of a variety of psychosis, for lack of better words or whatever, in the moment. So they can't go there, right? They're not able to. So by adding primary care to the model, people are able to be seen and met where they are or where they want to be. Or a story is, or at the transportation center, downtown Brattleboro, in the alleyway. That happens. That's an actual story. Somebody was getting their leg checked out for cellulitis in the alleyway. And then we're able to get brought to the emergency room after that. But so people are able to get that level of care wherever they are. The second piece is traditionally peer support in, like many organizations, is co-opted or tokenized in a position of the least amount of power in our organization. So we wanted to shift that by having a different leadership structure where someone in a peer position role could have influence. Their voice could be heard in policies and decision making, in positions of power, in an equitable way that felt good. So that is another shift. So because of that, we have a peer support lead. That's what I do. We have a medical psychiatric lead. So that person is dual certified currently at the moment. They are a traditional nurse practitioner and a nurse. What's the nurse? A psychiatric nurse, like APN. I don't know what the other one is. Sorry. And a social work team lead. So we have 3 modalities of care providing the next slide will say, a triad model of leadership. And then the third thing that we're doing differently, again, is what we've been speaking a lot, is really having buy-in from a variety of different agencies. So that is Groundworks, HCRS, which is the DA, Brattleboro Memorial Hospital, and Brattleboro Retreat. So this is a picture of, we got a space where we have our own exam room, where people can come off the street and get blood work, wound care, EKGs, COVID tests, injections for psychiatric medication that can all be done here in an environment that is directly right next door to the drop-in homeless shelter. So people that are staying there could be getting needs met here. And again, just to reiterate that we are all using BMH's medical record. So the services we are all providing are going into that record as well. And so the other piece is peer support. So how we are doing it different is on our team, that we really wanted peer support to be like lifted up, and this voice is to help reduce the co-optation of peer support, like I said earlier, to provide a connection to the larger psychiatric survivor movement. We're really good at providing alternative perspectives and meeting people where they're at, right? Again, like, so we're removing the barrier of people being in altered or extreme states receiving care. That is a huge barrier that people have, going to a therapist, going to a doctor's office. And we do our best to represent the voice of the psychiatric survivor community and agency practices, policies, culture, and to help move the system to a more holistic, non-pathologizing, and rights-conscious approach. So everybody wants to know, what is a triad? We call ourselves the triad. That is this latitudinal model of leadership. So we've got the social work lead, myself, and a medical lead working in tandem or triad, not tandem, in triad, to provide oversight. So I oversee my peer support advocates. The social worker would oversee case managers, therapists, and the medical lead would oversee a nurse practitioner, RNs, and we work together because there is in this work a lot of grit, right? So it's kind of interesting. So I'll pair up with an RN, right? And we'll go out and do a lot of like medical questions. Even though I'm not a nurse, I'm not going to like provide medical care, but I might be checking in with somebody. Do you need a nurse, right? Or do you need me to go and get somebody? So there's a lot of overlap there. So we need to work really closely together. And we meet regularly and have reviewed the work we're doing. Leadership of persons with lived experience, a constant quality improvement by consistently communication between medical providers, mental health and addiction treatment providers, and peer support advocates. So that's that like constant checking in. Are we doing the work? Can we be doing the work better? Is there any shift we can make? Really holding each other accountable to this like idea that we want to provide the best care we can, and we really can't do that unless we're holding each other accountable. So in addition, the leadership team will focus on building a culture that is patient-centered and trauma-responsive, prioritizing a team culture and staff education.
Great. Thanks, Curry. So Curry spoke a lot, obviously, about the ACT team itself. And as Becky sort of queued us up earlier, we did also want to highlight what our LLC structure looks like. We're fortunate enough to have 10 positions in total funded for the ACT team itself. Our goal is to move towards a patient panel size. We'll have about a 10-to-1 ratio of staff to clients. As you can see from this graphic, we do have, our goal with triad leadership, shows Curry as the peer support lead. There are 3 positions, 3 FTEs supplied by HCRS. The social work line has 2 social workers who are employed by the Brattleboro retreat, and 2 case managers who are employed by Groundworks. And the medical psychiatric line has 3.3 FTEs that are all employed by BMH. Some of the components, just beyond team leads, beyond that, we do have, as you can see there, a steering committee that we've met pretty much weekly since implementation, and are actually in the startup phase realizing that we're going to expand our time a bit to address some of the challenges and, things that a program's designed in an ideal state, and then life happens. And so we haven't allotted enough time in our busy schedules to get 4 different agencies together as much as we thought. So we've expanded our time there from a steering committee perspective. And then beyond that, we have a managing board collected of executives within each of our joint agencies. The overall criteria for clients to participate in HealthWorks Act is also something, as you heard in how Becky queued us up, to be somewhat unique for the collaboration that we have. The model was aspired to address and serve really, I describe it as a innovative homeless healthcare model meant to go out and serve individuals who are traditionally hard to reach, as you know, typically wait to do any preventative services, and we see them more show up in emergency rooms, emergent care, or sometimes we don't see them at all and we miss them completely. So this model was really intended to address solely that population, primarily that population. All of our referrals for HealthWorks Act need to be generated by a staff member at Groundworks. We have referrals from our shelters, from our permanent supportive housing sites. So even though we have folks who are in housing, as you may know, just because you put someone in housing, even housing with supportive services, a lot of folks that we have so many complexities to them that the ability that the ACT team has to truly meet, transport, be mobile, and have all the components of therapeutic support, peer support, and having both medical and psychiatric care embedded have been really significant to serve individuals with such complexity with sort of one broad brush, right? That's the ideal. They have the team, they can trust the team, their team can be consistent, and through that development of relationship, somebody who might have been closed to an idea on day one can develop trust to hopefully take recommendations, supports, or other ways that we can, be innovative in terms of meeting their individual needs. Additionally, there are other ACT models that have typically had an inclusion criteria that are based on a mental health diagnosis. And the way that we formed our ACT team still, of course, does give weight and significance to what a client's individual mental health needs are, but we've really tried to focus on the functional ability and impairment that they may be facing rather than focus strictly on diagnostic criteria. Additionally, there are many other ACT models that have, some may be serving folks who are compelled or involuntarily receiving ACT services, mandated to receive ACT services and other program models. But again, our ACT model is very much focused on this is, a service that the client is going to truly understand and receive and provide informed consent to receive the depth of services. It's something that we found has taken more time to get, for instance, from referral to admission in the process, because we really want to make sure that individuals are understanding the complement of services that they can receive. There are some ways that has not necessarily been challenging, but since we do provide, a depth of services, sometimes people who do have established providers have had some hesitancy in terms of they don't have to leave any established providers, but it's a complement to folks that they may already be seeing. We wanted to make sure that as aspirational as the model is, we're also, giving the full picture and talking about some of the challenges that we faced in implementation. One of the things that has been really tragic overshadow of our startup phase is in early April of this year at Groundworks, we had the loss and death of our shelter coordinator, which has had really significant impact well beyond just Groundworks staff to our HealthWorks team and truly the entire Brattleboro community. It's shifted rather rapidly how we thought about the work, our safety, staff fatigue, and how we take care of our own mental health needs and wellness as we continue to serve really complex individuals. It's been a challenge from our side as staff, and also superbly challenging for the individuals that we serve and the stigma and fear that they continue to face as well. So I do think that it's been a really horrible and significant piece of the story that we've been living since implementation. We have found that as valuable as it has been to have collaboration and support across 4 different agencies, it's also been really complicated to, compare things that we thought, I don't know that we thought that they would be so simple, but things that have provided to be complex in terms of, personnel policies and, having a consistent on-call rate for unionized employees and not across different agencies, transportation, all these different things that are, really the nitty-gritty details, but do require work and a lot of different collaboration and discussion to really hit all the nuances with that many parties involved. We also, you saw the model that we've had in the previous slide, and we recognize, sort of living in the work itself, that there are some things that we have aspired to that being in it, we need more time with. One component in particular has been really figuring out and embracing the elements of truly sharing what latitudinal leadership means and having meaningful incorporation of our peer support staff members. Some valuable things in terms of we do have a consistent, one EMR that the hospital provides, so everybody documents there. But there then are all these different home emails and who uses, a Teams app or Google apps. And sometimes it's just complicated and difficult, even just to find shared schedules in terms of where we can all see the same thing. So small things, but still important in terms of the ease of the work. Additionally, working to introduce what ACT is has been, it's a startup phase. Every time, it's not like clients or the community really understands what we're providing or offering. So it's taken time and continues to take time to ensure that individuals that we're trying to serve understand what we're able to offer and supports. And we are seeing, more and more integration as, I'd say both shelter staff and community providers understand what we can do and provide. Already highlighted, collaboration is extremely important, but does take a lot of work. And it's funny, I think that it sounds nice to talk about how, Kurt and Becky have worked together for years, but we were naming too, we have many colleagues that we worked together for a long time, but really having a spirit of partnership, approach, openness, and creativity together, I think goes a really long way in terms of, not naysaying, why someone discharged someone or didn't pick up something else. Really important things that may sound small, but I imagine you all can picture some relationships that with some additional finesse, when you show up and someone's pleasant and enjoyable and can, really listen to you, it is meaningful in terms of what you can share and how you can collaborate. It has been an essential building block that we've come back to many times, especially in this startup phase. We talked again about the time, and as Becky already referenced, the insurance piece was quite significant for us. The LLC is an exciting and innovative approach, but one of the complicating factors when it went to go to getting insurance was that none of our team is actually employed by HealthWorks. So there were some logistics to get through, and it did actually delay the start of services for around 6 months, which is pretty significant. And we've also found how important it is to have ongoing flexibility to change and be nimble. Ongoing, our HRSA grant is for 4 years of funding. And what we hope to do within the time is to demonstrate that our data around complexity and the services and supports that we're providing to our clients, and hopefully explore ways that we can turn on Medicaid billing with ACT codes to have reimbursement and billing for our services. One of the positions as well that is built into the grant and the program overall is a data specialist. It is also part of the ACT Fidelity to have fairly robust tracking and data development. So it lends nicely to being able to speak about, track, and document the work and the results. Additionally, to really speak to our audience, I think it felt like a real opportunity to really highlight how significant hospital partnership and hospital leadership is in a program like this. I worked at Rutland Regional for 10 years, so I'm coming from the other side of things, being on homeless services, and have lived a lot of ways where I think that hospitals don't always see themselves, necessarily stepping into homeless services. But certainly all those folks know how to reach us. I think that hospital leadership in this model in particular, both from BMH, but also from the Brattleboro Retreat as a psychiatric hospital, has lent a really significant component to things, as Becky said, that we can't all do together. We know that we're better if we can partner from our designated agency, homeless service providers, psychiatric medical leadership. But I do think that there are many, many things and resources that hospitals bring that are extremely important in not just starting a conversation, but really allowing it to move forward and lend credibility and resources that you all have power to initiate in, I think, ways that are incredibly significant in communities throughout Vermont that have collectively so many small different pockets. Hospitals are natural places that so many community resources rely on and benefit from. So I think leaning into models like this has deep community impact, but also really meaningful life impact on clients and also the staff that we support as well.
So we have this sort of nice tradition that we've invented in the managing board meetings where the executives get together to talk about all manner of things, including sometimes the mundane and the practical, that as we get started, that we share something about the work's impact on an actual client in the start of each one of those meetings. So to close today, I thought we'd share one of those that came up recently in a particular case. This is written a little bit formally, but I'll summarize it with a participant who was new to us, that was immediately in what we would think of as a manic psychotic episode, who was sort of behaving in ways sort of different than they had been before, had been quite aggressive, had been asked to leave the shelter, I think, a couple of occasions, and was literally sort of running around the community kind of chaotically, and actually jumped over a fence, I think, and fractured an ankle. And then we were trying to get him into the ER, and it probably needed a surgery. And then he was somewhere else. And then he was in New Hampshire, and then he was here. And we're sort of chasing this. Now, very often with bipolar mania, you have to wait and hope that somebody doesn't sort of do lasting damage to themselves and their lives. There are not a lot of things you can really do. But here in this case, we had an ACT team that was able to sort of, I don't know that we got out ahead of him. That's pretty hard to do, but we were able to follow pretty well, and were able to sort of stave off an involuntary hospitalization. We were able to sort of engage with him in a way that, although difficult, was able to sort of prevent further medical complications and damage, and engaged with him very flexibly, very, very flexibly around introducing psychiatric medications around, and since then, he's really done a lot better, actually. Has really stabilized and is still living in the shelter, has maintained that, is on psychiatric medications. Never did get the ankle surgery, but he seems okay. I know people do what they do. And is actually looking for a job. And so it's sort of powerful turnaround. And I think that's not... it's not an atypical story. In the first couple of weeks of this, like very literally and non-hyperbolically, we saved a couple of people who definitely would have died from complicated medical and psychiatric complications. We definitely prevented people from being evicted from their housing into a sort of spiraling cycle of psychiatric and medical problems. And this is just sort of one among many sort of hidden stories that really never get told. So we're trying to tell them here.
Dr. McGraw.
Can you speak to, you talked about the funding in that, but can you speak to the expense of what it costs to do this and what it might cost into the future in terms of going forward?
Yeah, so initially our budget was $1.3 million. And I think that's actually a little bit on the low side compared to where we're at now. There is money to operate the LLC. That costs money that we need to be able to fund that. But, I think in terms of things that we didn't know that we needed was more support for our staff and things like that. So we have to figure that out in the next year's budget to be able to work those in. We did have the funding from HRSA, so we have about $500,000 for the next 4 years. We received the earmark funds of $681,000, and we have not used all of that, so we're carrying that over to float us into year 2. VDH was phenomenal. We received a COC equity grant. Con is here. That was enough to bridge some services for us during this time. And the private funding from the various organizations that we received was great as well. Was there something else specifically that you wanted?
Thinking about the cost per patient and the cost of
Yeah, so the typical cost of an emergency room visit, don't quote me on this because I can't exactly remember, but $1,500, $2,200, around there, inpatient hospitalization, regardless of emergency room or inpatient. We are looking to be able to provide the services to keep folks out of the emergency department and out of the hospitals as much as possible for less than that a day. So, I think as we think about it from a statewide perspective, as we think about healthcare reform in our state, how can we do what we do in a better way for people in the community, keep them out of the hospitals and the high cost care and serve them in the communities where hopefully we can extend their stays outside of the hospitals. So not only is the program good for people so far, time will tell, 4 years, I guess, but it's actually less expensive to provide the services. We do have to scale it because that's a lot of staff, but really with the ratio of 10 to 1, the more people that we bring into the program, the more sustainable the model is from a potential reimbursement state. Other states provide, approximately, depending on how well they score in their fidelity model, which holds people to a certain quality of care, they're able to sustain this based off of that reimbursement and be self-sufficient without multiple layers of funding.
Becky, do you want to just add? I just want to add one other piece that, in terms of the model itself for services, we're scaling up to be providing support 7 days a week, and already have 24/7 call support in place. So it's another way that clients can access quickly trusted resources and supports that would hopefully prevent them from ER care or emergent care as well.
Yeah, more expensive levels of care for sure.
What parts of the ACT model did you want to de-emphasize or remove, and how were you still able to use that term even with the modification?
That's a good question. I think the traditional ACT model is basically very much centered in hierarchy, a leader, and then the staff. And that's very familiar to us in healthcare, for sure. It's how we operate. But I do think that not elevating the voice of peer support is a disservice to the traditional model. So that was one area that that we really wanted to emphasize. You know, historically, peer support is on an ACT team, but not in a leadership way. So elevating that voice, I don't think actually changes the fidelity model per se, or the points that we would get using the fidelity team ACT model. Where it does get potentially interesting is around primary care, because there isn't really primary care built into the fidelity model per se. So that's a little bit different. And I think those are the two big areas. Was there one other, Kurt?
I just had a couple of things. One is that in a way we're serving a slightly non-traditional population with it. I mean, they're largely folks that would meet criteria for so-called severe persistent mental illness, which is the group that was sort of tested for on an evidence base. And some of those folks in other places might be homeless or experiencing homelessness. But I don't know that we found any other that is sort of exclusively working in that population and that really doesn't also restrict people with co-occurring substance use disorder. Now, it doesn't count against you to do that, but it might make it harder or need other interventions. Mm-hmm. I also think that there are places where I think it almost sounds like from a sort of overly simplistic way that what you really want is like a provider, like a nurse and a psychiatrist to go out to where the client is and shoot them up with a long-acting injectable antipsychotic. And I think there are people that don't want that
mm-hmm.
still need a lot of help, actually. And I sort of was trying to get to in the history that maybe actually that's our target demographic, is the people you put a trauma specialist next door and they say, no, thank you. You put a psychiatrist in and they say, I don't want that. You put a doctor in to bandage the wound and they say, I'm good. So we had to sort of some of it was sort of knowing our audience and sort of knowing our values. Also, we don't want to replicate that. Early on in the process, one of our other peer support contributors in this sort of had a slip of the tongue and called it aggressive community treatment. And I think that is sort of, and we all kind of went, yeah, I can see that. We don't want to be that. Exactly
right.
Like that. But we have yet to get a fidelity score, but hopefully some of these interventions won't count against us too much. So.
And I think to your point too is we're trying to figure it out. I think it will impact our score, but is it a score that we collectively can live with? Right? Is the quality of life better for the people that we're serving because of these interventions? That is really what we're talking about here. I mean, we can talk about money and we can talk about sustainability, but really when it comes down to it, we're in healthcare because we care about people and we want them to be better and not be harmed inadvertently by the services that we all provide. And so we might not get a great fidelity score because of the way that the fidelity model is, or the fidelity rating is established. But we need to start somewhere. And so we do actually have, her name is Susan Challen. She is grades, if you will, ACT teams in Maryland. And she is, we have contracted with her and she will be providing an actual fidelity score for us. Halfway through our program, we're going to take a little bit more time because of our delay, and then at the end, and we'll have conversations with the managing board of what can we live with for a score, what can we not get points for, and what do we really need to improve because it actually improves the quality of care for the people that we're trying to serve.
And she has made the point that no ACT team scores perfectly, that there are always choices that we make based on the situation we're dealing with to sort of emphasize one thing over another and sort of live with that and maybe not make adjustments in other areas. So.
Which broke my heart because I always want a perfect score. So I'm really glad she established that right up front, that I was not going to ever get a perfect score. So I was like, okay, fair.
How many clients have you seen since February?
So
how responsive are they to your intervention?
So we have we had currently 12 participants in our program. Since February, we did have one participant who recently passed away from an accidental, I don't even know how you say it, accidentally. We'll just leave it at that. And we had one participant who actually did need to go to inpatient care in a more residential way. So after the tragedy in April. So currently we have 10 folks. And I would say that I have known some of these participants for a long time as I live in the community. And to watch the team engage with them and see them in a different way and work with them has been amazing to watch. To have one participant specifically call the team on a phone by the correct phone number and say, hey, I just wanted to check in and see what you guys are up to. Like, this is somebody who is very disorganized, but for some reason, somehow managed to A, find their phone, and B, call us was by far amazing. So, I mean, I think we have positively affected each person's life in various ways, if nothing else than to just show up, to check in, to look at them and say, we see you as a human and we're here.
Becky,
Regardless.
Could I add something?
Yeah, please, Curry.
Our panel seems really small, and I think we do a really intentional, longer engagement thing because we really want people to consent. And the huge benefit here is exactly what Becky is saying is we are developing amazing relationships with people that have not ever probably, for some of them, ever been able to do that, like ever been valued or viewed as somebody that a provider would maintain relationship with. Like majority of the people we are currently supporting have not been able to ever have consistent relationships or show up traditionally at a provider's office. Some of these people, maybe it's probably been decades since they've received care. So it's a slow burn. Like, it's really slow to move the needle, like for like treatment per se, right? But the impact is the relationship that's happening with these participants. Like, that is huge. Like, people are we're consistently showing up for people in a way that is meaningful to them.
And we were, just to emphasize again, we were frozen for intakes for a long period of time because of the tragedy of Groundworks. And so that's
We've also noted that most of our referrals, one of the other challenges that we had more of a sort of responsible flex daily outreach team comprised of a nurse practitioner and other supports that actually went away in May, unfortunately. So we're finding that many of our referrals are coming at a time where the client is in highest need and often really challenging to reach, really hard to engage. And so that lead up time from referral to admission is, a component of introducing the services, but usually introducing it to somebody who is in a state of crisis or disorganization. We've outreached people in hospitals and other supports, the ER and other places where they need care and we're building linkage, but it's not quite that quick flip over. We may think that it's very obvious very early that they would benefit from services and we would like to receive that and we would like to offer them to them. But again, to Curry's point, ensuring that they have meaningful consent and understanding and meet with the team has been an important component of the model.
Okay. Our email addresses are in here, so please feel free to reach out to any of us. We are actually touring a health service area, Blueprint Program Manager, and other community partners in October. So each one of your health service areas has a Blueprint Program Manager. So find them. That is my position down in Brattleboro, and connect with them, and we can get some of these tours or conversations set up in each of your communities. So thank you very much, everybody.